providing youth and families with the resources that they need to find help and hope. And Sherry, I will turn it over to you.
Thank you. Hello, everyone. I'm glad to be here with you all this afternoon. You're probably hitting that lull, so I'll try to be super engaging. Like Amanda said, my name is Sherry Burkhard, and I'm the Executive Director of Rise Against Suicide. Hang on one second. All right, making sure I know how to switch my slides. Okay, and as we've talked about throughout the time that I've been here today, suicide can be a really hard word for people. What we've noticed, and my counterpart, Monica, if she wants to raise her hand out there, our community engagement manager, is that we have the word suicide in our name. And so that often means that people go to introduce us for something and they'll say, Sherry with Rise Against, and then they stop. And I'm like, okay. And so recently I was at a realtors group that I was going to be speaking to about one of our events, and they said that, and then I got up to the podium, in huge, it said Rise Against Suicide, but she had stopped at against. And so we know that people have a really hard time saying that word. It brings up a lot of different things. It may be grief, it may be stigma, it may be pain or shame for something that we've experienced. And so we find it really important to have that word in our name. And the other reason I say that is because I speak a lot to not just mental health providers, healthcare providers, because my background is I'm a nurse. And I find that it's always really important to start this conversation with what is the lens through which we see this topic, because we really need to identify that for ourselves so we know what those unconscious biases are that we're bringing to this topic. So I'm going to share mine today. As you can see, I am a registered nurse. I've focused my career on psychiatric nursing and inpatient and outpatient settings with all ages, as well as I spent a large amount of time in community mental health. But what drives my passion is the acronym that's not up here, and I would call that my triple P. And that's the fact that I am a person who has struggled myself and was hospitalized for suicidal ideation as a youth. I am a person that has lost many people in my life to suicide, family, friends, and patients, so I've experienced that grief. And then I am a parent, and I have had a child who is now a young adult that struggled extensively with suicidal ideation. And so those are the things that really I bring to the table, not just my professional training, because I find that that's often the way we open up the conversation, is not with telling people how to do something, but opening up with the fact that we've been there too. There we go. So a little bit about why Rise exists. When people talk about youth suicide and even the youth mental health crisis, a lot of times right now they're coming from the lens that it started with the pandemic, and that's not the case. You can see from this graph, these are the crude suicide rates for youth in Colorado from 2010 to 2020. And steadily, they were increasing. Rise started actually in 2009 out of a suicide cluster that happened in Jeffco. And so we existed prior to this escalation. But by 2020, we saw double the amount of youth in Colorado that were dying by suicide. So previously, actually, when I came to Colorado, I was working at Children's Hospital. And what happened in 2020 was the mental health in chief, Ron Lee Liao, declared a state of crisis for youth mental health. And she was the first children's hospital across the nation to make that cry for what was going on. And a lot of times people think that that's because of these increasing numbers, and that was part of it. but it's also about that access piece that we're talking about today. And the fact that there were more youth that needed to be seen, but there were not the providers or access to care that needed to happen. It was not rising at the same rates as what we were seeing. And so that's what led her, and then soon following many other children's hospitals, to declare that state of emergency. The good news is that we've seen a lot of improvement. Like previous presenter just talked about, there's been a lot done by the state of Colorado to address these issues, to have CAMS training for providers so they have that suicide prevention lens and they're informed. And so we're starting to see those numbers improve. This data is from Healthy Kids survey from 2023, but when I compare it to 2021, and I can't remember all these stats, so I'm going to read these, but that persistent sadness and hopelessness, high schoolers went from 40% in 2021 to 26% in 2023, and middle schoolers went from 34% to 24%. And then those that seriously considered suicide, high school went from 24% to 11%, and middle schoolers went from 24% to 17%. And then attempts, high schoolers went from 7% to 6%, and middle schoolers went from 9% to 7%. So it's nice to see any number is too much for me, but we like to see that downward trend. However, suicide is still a leading cause of death for youth in Colorado, and how you rank, if it's 1 or 2, depends on the age bands. And then we're also seeing the LGBTQ community struggling disproportionately to their heterosexual peers. I guess it's been in this month, probably within the last 3 weeks, that data came out that really did show overall as a state this decline and improvement in suicide. But there was an article in the Denver Post and the Boulder Daily Camera that interviewed Ron Lee Liao, the one I referenced earlier, the mental health and chief at Children's. And one of the things that she was talking about were the concerns that she still has, because over the summer, the emergency room department rates, the visits for youth in a suicidal crisis, continued to say high. And I myself have done mental health response in an ED in Texas for youth, and usually the summer is a slow time because they don't have as many stressors. And so over the summer here, we were continuing to see those high rates. And then we're also continuing to see that lack of ability to access. So only 50% of youth with a mental health struggle are getting access to a resource or connecting with one, and only 20% are getting connected to one that's a quality resource. And so that's why we continue to need to talk about access like we are today. So I made this graphic a while back because, again, I referenced that triple P, and as a parent, this is what I experienced, and then as running an organization that was geared towards navigation in the Houston area, this is what I heard almost every call from a parent. And that's the fact that they found out their child was struggling, they went to the internet. And like it was referenced earlier, there's a lot out there, there's a lot that's not accurate, and it's really overwhelming. And so then the parent usually goes to the primary care office. And at the primary care office, if they don't screen that they're high or imminent risk, if the primary care office is doing screenings, then they're given a list of mental health providers. And that list, the parent takes home and starts calling, and no one calls them back. They're full. They're not taking their insurance, and on it goes. So then the parent, or maybe at that point the school intervenes and calls the parent, or vice versa. School counselor realizes they're not at imminent risk, they don't need that higher level of care, gives them another list. The same thing happens. And then eventually the youth may find themselves in the emergency department, because all along the way, the times where there could have been intervention didn't happen. And so they end up in the emergency department. The same screening thing happens. They aren't imminent. they're given a list. And so round and round it goes. And like Ben talked about, many people give up. They don't want to go through this process. They have other life stressors happening. This isn't happening like in a bubble where your life stops and you're only dealing with this. You've got all the other things happening at the same time. And so that's why, one of the reasons why our organization exists. Other things that are happening are those barriers to care. Financially, and it was referenced up here earlier, we tend to think of underinsured or uninsured having the largest problem with access. But really, honestly, it's across the board. When running the navigation organization, talk to families with plenty of resources, but they just don't know what to do or how to access it. And that doesn't mean that a therapist that's full is going to change their plan for someone that has the resources or someone who doesn't. They don't. So it's across the board a problem. Then the availability of those providers, and particularly when you're talking about suicide, and Ben referenced this, a lot of providers do not want to see youth at risk of suicide. That's not in their wheelhouse, they're not trained, and so they will turn that away. Then there is the difficulty navigating the system, and then that lack of transportation. Parents are working. Schools don't want kids to leave. And sometimes the parents aren't supportive. So the mission of RISE is to help youth at risk of suicide by reducing the barriers that we're talking about and giving them timely access to funded therapeutic sessions, hopefully providing that hope and healing that they need at this time. So, like talked about earlier, we're really filling that gap in the fact that we're not crisis, but we're not long-term treatment. And we are able to mobilize quickly and with funded therapy. So we see youth 19 and under that regardless of their funding source, we don't even ask that. And that's one of the things that we recently brought in subject matter experts. So the Department of Suicide Prevention, Lena Heilman, someone from SAMHSA, someone from overall in the schools, and looked at every part of our program. And one of the pieces they said is don't start asking about insurance up front, because even if they have insurance, maybe the parent can't pay the copay, or maybe the stigma is too much. Just don't even make that part of the conversation. The point is getting them to the help they need right away versus bringing that in. Then we see the youth that live in Boulder Valley School District, St. Vrain School Districts, and those surrounding areas. We do have contracts with Boulder Valley and St. Vrain, so our therapists are able to go into the schools to see the youth. And I don't have my glasses on. Oh, yes. Okay. The parents and guardians, those important pieces. We know that kids, like Ben said, do not heal in isolation. They need that parent, guardian, or trusted adult involved. And so we encourage that involvement, our therapists outreaching, as well as part of what we do when parents outreach to us directly is to help equip them, help explain what this experience is going to be like. Because so often parents are going into it and they have no idea. And that fear adds to the child's struggle, it adds to the parent's inability to emotionally regulate and therefore focus on their child. And there's research that talks about the fact that one of the things the kids want most in disclosing, if they disclose that they're feeling suicidal, is the parent to be able to emotionally regulate themselves in that instance. And I can tell you that as a parent, that's extremely hard. And I'm a parent that has many years of recovery from my own disorders. I'm a parent who has worked in the mental health system. I'm a parent that's worked in the children's hospitals. But when my child came to me and started sharing these thoughts, it's a whole different ballgame. Just like my child who had medical issues when he turned blue and I had to do 911, like all of my nurse training, boom, out the window. because it's just different when you're the parent. And so we want to make sure we're helping parents show up as their best, regardless of their background, because that is hard when you have that background and you know your kid's struggling. So RISE referral criteria, we really have honed in on in the last 8 months that I've been at RISE. And so we know that there are resources in the community, and our specialty is really meeting this need of those youth impacted by suicide. That's the gap that we're trying to fill. And so what referrals are a fit for us are those youth that screen positive. Often that's because they're in schools or in a community setting where that screening is done. The imminent risk or immediate crisis, those aren't a fit for us because we are not open on weekends or 24 hours a day. Then we see those kids that are stepping down from a higher level of care, be it that intensive outpatient, primary or PHP, residential, or an ED visit. And they really need to get in to see someone, and that transition time is a really vulnerable time for that youth. Statistics show us that they're at higher risk of suicide at that point. A recent loss of a family member, a friend, or someone else in their life to suicide makes them more vulnerable. So that's another referral source for us. And then some of our kids are really wise to the system, and my son was one of those, where they know what to answer to not have to do these things. And so if we are hearing, or school counselors hearing warning signs, but this youth is not screening positive, we still want to see them. We want to have them further evaluated. So they may get in and have a shorter duration with us because we may find out that that's not necessarily the issue, and then we're going to refer to other things, but we don't want them to go unseen and have that be missed because kids are smart and they figure out the system. So our model is that we meet kids where they are to reduce those barriers. So just like Ben talked about, we want to see youth in schools if that's what works best for the youth. Maybe it's in their home, maybe it's in the library in a private room, but whatever is a fit that we can go to them and see them, we do that. Our therapists are flexible about that, and we reimburse them for transportation. We really recruit therapists with a diverse background, lots of different modalities, but regardless, they have to have at least 3 years of experience doing some sort of suicide-related crisis care or training in CAMS or brief CBT, as well as a few other criteria. So we really look for counselors that this is their specialty, not just seeing anxiety. We want them to be able to treat these youth. And then they're screened using the Columbia SSRS 3 times during their time with us to make sure that that risk level is going down, and also to help guide the therapist on if this model is working or if they need a longer term source of care. So a little about how it works. There's a couple of different ways that youth could come to RISE. It may be the school, from school counselor or mental health advocate. And so we have an online referral system that they're part of. So they go in and immediately enter that referral into our system and reach out to a therapist. Like, they have those relationships, and that really helps cut down on our length of response. They can respond within 24 hours. A lot of times it's quicker. It just depends on the time of day or if how long it takes the school counselor to connect to a therapist. Parents or youth 12 and up can contact us directly, and then the RISE staff is acting on that part as looking at risk and what's a fit in making those connections. So then, once a therapist is selected, the therapist reaches out to that youth or family pending what's been decided in that connection process, and they have to have a direct conversation to set up services. And the therapist is usually contacting within 24 hours. So the majority of time, they're seeing this therapist within the week, often at school. So that's unusual compared to all the other wait times in the area. And then RISE pays that therapist directly for seeing the youth, doing the screening, and the family never sees a bill. We do 10 to 12 sessions because really if we're doing a short-term intervention like CAMS or something like that, that is the time we're focused on that, identifying what is the immediate issue, and starting at the beginning of the sessions really looking at, is this child going to need a longer-term issue? Do we need to get on a wait list for medication? And really start that process so they're seeing a RISE therapist while they're waiting for those other services, but they're not just falling in the cracks. So in 2025, which our fiscal year runs from July 1st to June 30th, so 24-25, we saw 525 referrals. We funded 5,200 sessions of therapy. We had 36 licensed clinicians at our network, and we have a really strong utilization rate of our services because of the fact that we're working with the schools, those community partners, as well as making those direct connections. And just like Ben talked about, that's so important, even working in navigation for all those years. That warm handoff makes a huge difference. If I had a t-shirt that I wore, most people would know it'd be like no lists. I do not care for lists because I, as a parent, don't find lists effective. As well as when I was working at a large children's hospital and started calling the people on the list, I found out one of the psychiatrists had died by suicide 5 years before and was still on the list they were giving family members. So lists are outdated, and so we want to make sure that people are really getting that warm handoff and that connection. Other ways you'll see RISE in the community is through our Emerge 5K that we have in May. I know several faces and people that were there, but this is a way that we honor people who have, or memorialize people that have lost their lives to suicide. The course is lined with butterflies in memory of youth and other people. And it's also a time where people can really come together and break that stigma. Great conversations happen. And it's an interesting coming in new this year and it being my first time to do this event. It's a both and. It's a way to hold space for grief and also a way to find a way forward. And so it's extremely powerful. And also listening to our youth who attended and the conversations they had with their parents and with others, it's really a way that we can say the word and it not be scary and hopefully then create change in our community. So that's every May at Boulder is what we call them, that have the names of youth, and people can donate to support those youth in getting therapy. But the other piece is they really are a conversation starter. Before I even came to RISE, when I was working at Children's, someone came into our staff meeting and was like, I saw all these Christmas trees in Boulder, and they're for youth at risk of suicide. And so I started telling my neighbor, and I found out they needed help. And so I connected them, so it's not just for us to raise money. It's a way for us to start a conversation. So we have information on the table. We're always available to talk. We have a webinar coming up the 29th, Monday the 29th, just explaining levels of care and what parents and youth need to be looking for or expecting in this process. And we're always out in the community. And so reach out to myself or Monica, as well as Monica has been doing an amazing job for Suicide Prevention Month on social media. And so those are great things to share. There's lots of education and encouragement all throughout this month because our focus has been on having these conversations and how to equip the community to do that. Thank you so much.